the co-chair of the World Federation Committee on Cerebrovascular Disease. Michael, we can see your screen. Go ahead. Thank you.
Super. Thank you. Can you hear me? Yes?
Yes.
Okay. Thank you very much, Giuseppe. So, hi, everyone. Following Vincent's excellent lecture on the surgical and geographic anatomy of ACOM aneurysm, I would like to share how I apply this information in surgery and offer some tips that I believe will be useful. To illustrate this, I will discuss 4 different domes orientations of aneurysm. The direction of which the aneurysm is pointing will influence your approach and the dissection technique. It will give you the how to access the proximal. It will give you the way to access to the proximal control, which means both A1 segments, the steps in relationship with the perforators, how to dissect the aneurysm, and the clipping technique. So I want here to emphasize first that the importance of being aware of anatomical variance in each case. In addition, when there is a bleeding, when the aneurysm have ruptured, it's crucial to remember that the brain vessels may be obscured by the presence of the blood, and for the variance, here you can see the presence of a median artery of the corpus callosum, which is a very important artery when it's well developed like this, because not only it will supply the subcallosal area, but also it can give branches to the hypothalamus. And again, I would like to emphasize how important it is to know the vascular anatomy, the angiographic anatomy, but also to have a good knowledge of the functional anatomy. I'm sure this knowing what you are retracting, what you are mobilizing, or what you are. So if you understand this area, I'm sure you will manipulate differently the brain, this delicate brain tissue, and you might want to reduce your as much as you can the manipulation and retraction of the brain. So this is an example of a patient with the median artery of the corpus callosum. This is a ruptured aneurysm, and you can see how it's important to preserve this very important artery. And this means that you have to recognize this artery, to not just looking at both A2 on each side, but also to find this the median artery of the corpus callosum, even if this is hidden by the blood. So this is the post-op angiography and the CT scan, which show very good exclusion of the aneurysm, and you still can see this median artery of the corpus callosum, which would be it would be catastrophic if we occlude this artery, because this will give at least some severe memory deficits because of the subcallosal area. It provides flow in this area. So for most ACOM aneurysm, I prefer to open the system widely and very widely. We know that we should employ all possible strategies to work on a relaxed brain, because we want to minimize manipulation and retraction of the brain. However, even with a relaxed brain, opening the system helps further reduce retraction. When you want to expose the A1 portion, if you do not open widely the cistern, you have to how to say that, to contend with the temporal lobe. So because the arachnoid is attached here with the temporal lobe, if you have to expose this, you have to contend with this the temporal lobe. So if you open this, you will reduce the need for retraction and the force you will apply in order to expose that. And this is the same thing. This is exactly the same when you want to expose the ACOM complex. If you want to expose the ACOM complex here, if you try to retract the frontal lobe, this is attached with the arachnoid to the frontal lobe of the other side. So this is the reason why in most of my cases I open the interhemispheric fissure here, and this will not only reduce the need for brain retraction, but also reduce the need for a brain resection, the gyrus rectus, even if it's a small amount. So this is an example of how I open this. You can see this is on the left side. You see the left and the right optic nerve. You see the interhemispheric fissure, and this is the way I open the fissure. You can see, you will be able to see the internal aspect of the frontal lobe of the other side and expose. But I will show you more videos of this approach. So the first example is the aneurysm pointing anteriorly. So these aneurysm, the positive thing when you are for a surgeon is when you have this kind of aneurysm, approaching the aneurysm is most of the time not a problem. When you mobilize the frontal lobe, you usually do not mobilize much the dome of the aneurysm, so you are not much afraid of you are not afraid for the rupture aneurysm when you want to access to the proximal control. I usually, of course, when you deal with a ruptured aneurysm, you want to have the access of the carotid and the proximal control as soon as possible. So you go right away if there is a significant significant subarachnoid hemorrhage. You want a large craniotomy, and you need only 2.5 millimeters, the distance between the base of the skull and the brain, just to have access to these vessels, and to be able to put a temporary clip if necessary. And then if you have this, if you have access to this area, then you can go back and open the sylvian fissure from more distal and then going more proximal. So this will help to reduce the brain retraction. And of course, it's not so important when you deal with an unruptured aneurysm. You can just begin from the sylvian fissure right away and go down to your proximal, the carotid and then the A1 segment. As you can see, because of the orientation of the aneurysm, the proximal control from the other side is not difficult because you have the space and you can work close to the neck on the ventral part of the aneurysm, and it will be most of the time it's not so difficult to have the access on the A1 on the opposite side. Regarding the perforators are on the opposite side. So you are not much concerned about these perforators. And so these are usually, the aneurysm are not so difficult because of that, because then you can clip the aneurysm and the perforators are not usually on the way. And this is the example after clipping. I want to show you a video of that. So you see this aneurysm pointing anteriorly. Again, you can see the right and left optic nerve, opening of the sylvian fissure. Okay, I don't need here the retractor to do this. And you can see how you can expose the ACOM complex. You're approaching the ACOM complex and the aneurysm. Okay, this is an unruptured aneurysm. I like to open this fissure very anteriorly, so in order to reduce the need for brain retraction. So see, it's not very difficult to have the proximal control on the opposite side. This side, I almost always clip an aneurysm after having put a temporary clip, because I hate to put a clip on an aneurysm when it's under tension. So I like to do to decompress the aneurysm and then to clip. Sometimes, as in this case, when you open so extensively the arachnoid and the cisterns, the brain is falling down, so you need to put a retractor to maintain it in place. So, and this is, you see the post-op angiogram and the CT scan after the surgery. Whoops, why I cannot change my slide? Yes. Okay, so this is different for an aneurysm pointing inferiorly, as in this case. I'm sorry, I need to do something here with the, okay. So in this case here, it's the perforators, of course, it's positive for the surgeon. It's the perforators are away from the neck of the aneurysm, and the clipping is the same thing. You can put the clip, and there is less concern for the perforators. However, the approach is different. In this case here, if you lift the frontal lobe to have access to the proximal control, you can produce a ruptured aneurysm. You can rupture the aneurysm because it's attached to at the base of the skull or on the optic pathways. And if you pull the frontal lobe, you will pull the dome of the aneurysm, and it will rupture before you can reach the aneurysm. So what I do in this case is, again, in this case, I begin to open the external membrane of the Sylvian fissure. I do not open right away extensively the Sylvian fissure, but at least I want to open the external membrane. So when I approach the aneurysm, so I'm very close to the Sylvian fissure at that time, and I reduce the need for retraction until I get to the A1 segment of the aneurysm. Once you have done that, the game is not finished, because you need to have the proximal control from the other side, and this is often hidden by the aneurysm itself. And you cannot puncture the aneurysm, since you don't have the in order to collapse it, because the proximal control is not complete. So the way to do this is, it's not to try to find the proximal control passing over the aneurysm. I'm sorry about that. Okay, and you have to angle your microscope parallel to the A1 segment and try to reach this area just close to the neck of the aneurysm. And in fact, when you are doing this, you are dissecting, in fact, the neck of the aneurysm. And in this case, you can reach the A1 segment on the opposite side, and you have complete proximal control of the aneurysm. In order to, and this is after the clipping. So this is an example of such a case. You have this aneurysm pointing inferiorly, and this is the video. Okay, you recognize the optic nerve. Okay. See, this is the aneurysm, and then you go close to the neck on the ventral surface of the neck of the aneurysm, and you can see it right now here. And this is your temporary clip. This is the A1 on the opposite side. Now you have complete control of this. Is A1 on our side, and now you can deal with this aneurysm because you have complete proximal control. You dissect the neck, and I like these fenestrated clip, even just the way they close it. I think it's more, it closed very well the the neck of the aneurysm, then this is the case. Okay. And this is, again, this is the post-operative CT scan without infarction. So these aneurysms here are pointing superiorly. They are more difficult. The approach is fine. When you want to reach a proximal control, it's not so difficult because when you pull the lobe, the frontal lobe, the aneurysm will come with you. So it's less dangerous for the to tear the dome of the aneurysm. And so it's easier also to have the proximal control because the aneurysm usually doesn't hide the A1 on the opposite side. However, because it's you cannot see the dorsal aspect of the aneurysm, and you cannot see all the aneurysm, you cannot see all the neck, and you cannot see all the perforators. So you need to dissect once you have open widely your cisterns, you need to work on this area here where the ulnar artery is and the orbitofrontal artery. So you have to work underneath this area. And I will show you how I do it with another case, but this is the way you do this. Okay, this is behind you. You have to identify the perforators and to put your clip accordingly. Always for me, and almost always with the temporary clip on place on both A1 segment. But this is a situation much more difficult. This is you can see here. You don't see the aneurysm. The aneurysm is completely hidden. It's behind the complex of the ACOM aneurysm. So you don't see the aneurysm. You don't see the perforators. So for the approach is not a problem. You can have your proximal control quite easily on both sides. However, the dissection of the neck and the perforators and the clipping it's much more difficult. And the way to do this is to dissect in this area underneath the ventral complex. And again, in this case, I open widely, in most cases, even for the others aneurysm, but in this case particularly, I opened widely the entire hemispheric fissure. And this is a case. You can see how posterior is located the aneurysm behind the A2 segment of the anterior cerebral artery. So this is usually considered as a difficult aneurysm because of the perforators, and it's hidden on the dorsal aspect of the complex. This is the case sometimes when it's nice to have, you want to to remove the orbital rim in order to have, you can angle, if necessary, the microscope. Okay, but in this case, I have not done that. Okay, so this is the video. You see, this patient bled, I think it was almost over 10 days after he presented lately. So that's the reason why the brain is a little bit yellowish. Open widely the Sylvian fissure. It's not the Sylvian fissure, the arachnoid. It's very easy in this case. The optic nerve, the brain is well relaxed, and this helps in this situation. The carotid. Okay. You can see the old blood goes to the, so you open the Sylvian fissure, and I go down, and I like to see the carotid bifurcation. So I need to open what we call the proximal Sylvian ligament or membrane. So again, this is the opening of the entire hemispheric fissure. You can see how we see very well the internal side of the frontal lobe of the opposite side. I use here a retractor because just to maintain this, the brain is so relaxed that I need a. So you see the posterior part of the aneurysm, which is the part what I, and you can see now the perforators. You need to dissect. You need to identify these perforators, and again, I like to put clips. Usually 2 clips is enough, but in this case, I put 3 clips, and we have to deal with this perforator. So you have to manipulate a little bit the aneurysm and to slide your clip in order to protect this perforator. Okay, so you need to work on the dorsal side of the ACOM complex. And again, the aneurysm is clipped, and you can see how nicely the perforator is preserved. And this is the other segment of the aneurysm, which is very easy to clip. And this is the post-op. The aneurysm is clipped, and there is no lacuna or infarction or something like that. Okay, so when sometimes we have to open again the orbital rim, and this need to be done mainly when the ACOM complex is high, it's high compared to the in relation to the base of the skull. Okay, but so and in these circumstances, I think it helped a lot to reduce the manipulation and the brain retraction. But in some cases like this is really too high. As you can see, the ACOM aneurysm is just at the on the subcallosal area. So this is almost impossible to reach with the pterygonal approach. You will need in this circumstance to retract a lot your brain and to remove a lot of brain tissue. So this is the way to do this is by an interhemispheric approach. So almost all aneurysm ACOM aneurysm are clipped by the pterygonal approach, approaching from the dominant side of A1. But in this case, you need to go by an interhemispheric fissure from above. And in this case, we had the chance to have relatively large sinuses. So I decided to go through, instead of doing a bifrontal craniotomy, I decided to go through the frontal sinuses. And this is the way is the video working? Oh, sorry, I don't see my video. Okay, so this is the post-op, but where is my video? Sorry about that. Okay. Okay, I'm sorry about that. I don't have this video right now. You always, after having clipped an aneurysm, you need to assess your work. You want to make sure that the aneurysm is completely clipped. So you need to puncture the aneurysm and make sure that there is no bleeding, and also you need to evaluate the integrity of all the artery perforators. So, in conclusion, I would say that understanding the anatomy of a particular aneurysm with its surrounding structures help to anticipate difficulties, to develop strategies, and mainly to reduce the need of improvisation during the surgery. Thank you very much.
Thanks, Michel, for this comprehensive